Now, the next large genus we're going to talk about is Shigella. And Shigella, we talked about a little bit when we were kind of comparing and contrasting some of the organisms in the Enterobacteriaceae family. Remember, these are non-lactose fermenters, okay? So they're not going to acquire that pink color on McConkey agar. They are non-modal, non-H2S producers, okay? So those are some of the features. Now, if you look at the species of medical importance listed at the bottom of the slide, you can see that Shigella sonii is most common in the U.S. However, the most severe species is Shigella dysenteriae, and that's not the most common in the U.S. That's most common in developing countries, but it is the most severe. So in the case of Shigella dysenteriae, it only takes 1 to 10 organisms to initiate an infection. The distinguishing features we've mentioned a few times already. They're gram-negative rods, not curved or anything like we've talked about for cholera and Campylobacter, and they're non-modal, and remember, they're non-H2S producers. And much like we talked about with cholera, if you look at the reservoir are humans only. There are no animal carriers in this case, and transmission is typically fecal-oral, or it can be person-to-person. So anytime we're really talking about things that are spread fecal-oral, one of the things you're going to see, and this makes me cringe because my kids are in daycare, is you're going to see this stuff spread through daycares. So if in a vignette you have a child that attends daycare that develops a fever and the bloody diarrhea, then probably first on your list should be Shigella. Now, what's the virulence for Shigella? We've got quite a few here. It's actually a double whammy for an infection, okay? And here's why. Number one, it's invasive. So what do we talk about with invasive organisms? It's going to invade the mucosa, you're going to get blood and leukocytes in the stool, and you're going to get fever. In addition to being invasive, it also has a toxin that works the same as the toxin from enterohemorrhagic E. coli. So think about how that one worked, okay? It inhibits protein synthesis by interfering with the ribosome. So now we not only invade, but we secrete a protein that inhibits protein synthesis and starts causing cell death. So when we're talking about bloody diarrhea with Shigella, it's fairly significant because it's a bam-bam double whammy, okay? Now, the virulence for Shigella is interesting. If you think about the gut, okay, you've got the gastric epithelial cells, and every so often you have what are called the M cells. And the M cells kind of sample things in the gut and transport them across the M cell and deliver them to a nice little immune pocket sitting beneath the M cell. Now, Shigella gets taken up by an M cell, and it's looking down at that immune pocket. It's like, dude, I'm not going down there. They're going to kill me if I go down there. So what Shigella does is very similar to what Listeria does. It will get in the M cell and then cause the actin to polymerize and then push itself through neighboring cells. In that regard, it can avoid the immune system, okay? And once it does that, then it opens up the second can of you-know-what and will start making toxin. So we're invasive and we make a toxin for Shigella. Now, the Shiga toxin, again, very similar to the one from enterohemorrhagic E. coli. AB toxin interferes with protein synthesis by interfering with the 60S ribosomal subunit. One of the things I'm going to caution you, because this toxin is the same, basically, as the one from EHEC, what do we know that happens with EHEC in children that are 5 years and under? We talked about hemolytic uremic syndrome, okay? And hemolytic uremic syndrome occurs because the toxin from EHEC starts to bind specifically to the kidney as well, interfering with protein synthesis, causing cell death and necrosis. With Shigella, you also risk hemolytic uremic syndrome because the toxin is very, very similar. So that's another thing you want to think about, especially given the fact that you have a daycare setting usually as the backdrop for one of these cases. Now, the disease, unlike cholera that took, millions of organisms to get initiated, you need 1 to 10 of these bacteria to initiate an infection. So that's very few organisms. That means it's acid resistant. Okay, so it doesn't need to send a whole fleet hoping that just a few make it. It just sends a few, and they're resistant enough to the acidity in the stomach that they'll make it to the other side and initiate that infection. Now, we said it was invasive, so you will get a fever, okay? And like I talked about earlier, a lot of the times with bloody diarrhea, it starts off watery. So you don't always want to look for bloody, because if they talk about watery diarrhea first, maybe fever, and then they give you the culture information, and it fits for Shigella, but you say, oh, it's not bloody. You know, you have to go with the culture information that they give you. So if they say gram-negative rod, lactose negative, H2S negative, non-modal, in a case of diarrhea like that, you're going to be thinking Shigella, okay? Now, it causes watery diarrhea first, then bloody, once the invasion starts, and then that's just going to continue because now it's going to start secreting that exotoxin that interferes with protein synthesis. Severity depends on the age, and this is similar in most cases of gastroenteritis we're going to talk about. But clearly, younger children are affected a little bit more severely than older kids and adults. Now, the diagnosis, here's what they're going to say in the case. If they're not asking you to look at it just based on the clinical symptoms, which would be hard, they're going to tell you again, gram-negative rod, non-lactose fermenter, H2S negative. And by that information, you're going to have a pretty good idea that we're talking about Shigella. Now, how are you going to treat it? Again, even with Shigella, that we said is kind of like this double whammy. It's like, bam, we're going to invade, and then bam, we're going to secrete a toxin. It's still self-limiting most of the time. All right? In very severe cases, where we're really thinking dysentery, you would give antibiotics. All right? But most of the time, that's not necessary. And Shigella is a disease of poor sanitation. Not saying that our daycares are necessarily areas of poor sanitation, but just think about the kids, The kids scratching, they're digging, they're not washing their hands, they're touching toys. Another kid picks it up, and bam, you've just started, a little bit of an outbreak of Shigella.